Thanks very much. So, just get this working. No declarations of interest. And as Jane said, my brief today was to give an update on the GMC's current priorities in medical education, and to say a little bit about how that work touches international medical graduates, and to talk about my role, but I thought I'd leave that to the end if anyone was interested. So we've heard some of these quotes before, but I think the strapline of the GMC is working for patients, working with doctors. And I think we've heard from several speakers today that certainly William Osler put patients at the centre of what he did when he said a good physician treats the disease and a great physician treats the patient who has the disease. And in addition, when we're thinking about his work in medical education, he also put the patient at the centre of his teaching when he said the natural method of teaching the student begins, continues and ends with the patient. And Osler, in some of the reading I did prior to this talk, he really seemed to pioneer student apprenticeship in taking his students and getting them to work on the wards and in making sure they were prepared for practice, which is, of course, a fundamental principle of medical education today. But I wanted to talk about the priorities, as Jane said, about the regulation of medical education under these themes. So to sort of think about how we're working to shape training to meet the needs of the workforce and patients, to ensure that training is more flexible whilst protecting the quality of training and making sure that training is fair and that variation is reduced. I also wanted to say a few words about the work the GMC is doing to support the medical profession, which we know has been under pressure lately. So to start with, shaping training to meet the needs of the workforce and patients. So we know that we have a changing UK population. The population is becoming older, increasingly frail, more complex, and there's more people with multiple comorbid diseases and disability relating to those diseases, both physically and with their mental health. And we've also got a bit of an urban-rural split in that we've got more of the younger population in the urban areas and more of the older population increasingly in the rural areas. And these things place increasing demand on our health services and lead to the need to train more doctors, but doctors with the right skills, which are flexible, and doctors who are in the right place to treat patients. So there's things also changing with the workforce. It's not just the population. And just to mention a couple of those, so we know we've got more female doctors on the register, and as time goes on, as some of the more prevalent male doctors retire, increasingly female doctors make up a higher proportion of the workforce. We know also that what trainees and colleagues want is changing with time. And we know that more doctors are choosing to take a break from training. And this slide shows some work from the GMC a couple of years ago, and it shows the number of doctors taking a break after foundation training. And you can see the trajectory, which in 2019 is closer to 60% of doctors take a break after their foundation year 2 training. So these things are all having quite a major impact. But despite this, there's been a rise in the number of doctors joining the medical register, around 3.5% increase in England, slightly less in the other UK nations. And we've seen a doubling in the number of doctors who are coming to the UK from overseas. There's now 250,000 doctors on the UK medical register. And if you look at this slide, this is the number of UK graduates, and this is the number of non-UK graduates, which you see has gone up really quite rapidly. And we know that these changes in the workforce are having other changes in that now almost 20% a fifth of the UK hospital workforce are working in what we call locally employed doctor posts. So they're not in training and nor are they consultants. Many of these doctors are doctors who've come from overseas, and many of these doctors are the doctors who are taking a break from training. In addition, we know that there's a rise in the number of doctors in SAS posts, so staff grade or specialty doctors. And when we look here that whilst there's been an increase in other grades, the number of doctors in SAS posts has gone up a great deal. And this is a workforce that we sort of need to understand more what their aspirations are and what we need to do for them to ensure they can deliver excellent patient care. So how are the GMC supporting the medical workforce? Well, one of the things that's been happening, as we know, is there's been an increase in the number of medical students. Around 1,500 medical school places appeared a year or so ago, and the GMC has been supporting that increase and the development of the new medical schools. In response to that rapid increase in international doctors, there's been a huge increase in demand for doctors to take the PLAB exam so that they can join the register, and the GMC's increased the capacity for that exam by 42% in the last year. There's a lot of work also ongoing to try and help doctors progress to the medical register, and we're looking at reviewing the CSER process, looking at a wider range of evidence options to make it more flexible and more accessible, as we said, to doctors, SAS and locally employed doctors and doctors from overseas. But a lot of those changes need a change in the legislation, in the Medical Act, for that to happen. It's not straightforward. One of the things we're talking about, doctors coming from other countries to practice in the UK and how they now make up a vital and quite a large part of our workforce. And we know that it's really important that we support these doctors when they choose to come here, and that we support them with a good induction into the NHS, and that we welcome them into our practice. I just wanted to show people and introduce, if people haven't seen already, this course that's run by the GMC and has proved very popular to doctors from overseas, called Welcome to UK Practice. It's a free course, and the information about this is on the GMC website. So moving on to a different topic, thinking about priorities in education training, I just wanted to say a few words about the changes that are happening or planning to happen in undergraduate education and then in postgraduate education. So in undergraduate education, we've talked about the increasing medical student numbers, but one of the other projects the GMC is working on with colleagues in medical schools at the moment is the introduction of the medical licensing assessment. So the purpose of this assessment is basically, when we're talking about ensuring that training is fair and variation is reduced, the purpose of this assessment is to demonstrate that people who are registered with a license to practice meet a common basic threshold for safe practice in the UK. And this is, we've talked about the rise in doctors who've come from overseas, and they've come from many different medical schools with very different curricular and assessment systems. And in the UK as well, we now have 42 medical schools with 42 different curriculums and 42 different assessment systems. So even within our own country, as well as the international graduates, there's actually a lot of different ways of doing things in the system. And all of this does lead to requiring a basic level of knowledge so that patients can be assured that the doctor they see has reached a basic minimum standard to be registered. And the way that this assessment will happen, I thought would just outline the way it'll work for UK students and for international students. So in the UK, students will take the MLA as part of their degree, and for international graduates, they'll take this instead of the PLAB exam. And I can just talk through the model. Sorry, this is a bit of a busy slide. But if we just look first at the purple block, represents the MLA will be in two parts. So first of all, there's an applied knowledge test, which will be set by the GMC, standard set by the GMC, but working very closely with colleagues from across the UK medical schools. In the blue box is the Clinical Professional Skills Assessment, or CPSA, which will be different between UK medical schools and for international graduates. And this will be the clinical assessment, so like clinical finals. So for UK students, the knowledge test will be delivered within their own medical school at a time to suit their own medical school. And their CPSA will, working at the moment, this is sort of at an early stage of development, but basically the existing clinical finals will be sort of evaluated and meet the GMC standards, and then that will form the CPSA assessment for UK students. For international graduates, the knowledge test will be the same for the international graduates, but delivered by the GMC in various locations. And the CPSA for international graduates will basically, the PLAB exam will sort of morph into this, and again meet the requirements which are described to meet the standards. So this is obviously a work in progress, so just to show you the timeline of where we are now, that this is the piloting for the AKT and the CPSA assessments will begin next year, and the plan is for UK graduates that this will go live in 2024, and that's shortly before for international graduates. So that's, say, fairly soon on the horizon. So so that is a work in progress, and the GMC is working very closely with colleagues in medical schools to develop and deliver that. There's a lot more information on the GMC website about that, which describes the content map for the AKT and the sort of plans moving forward for the CPSA. So in terms of current priorities for postgraduate education, there's quite a lot going on in this field too. I wanted to focus on the aspects about making sure training is more flexible. So a couple of years ago, as we all remember, following the industrial action, etc., the GMC were asked by the Secretary of State for Health at that time to undertake a review to try and improve the flexibility of UK postgraduate medical training, because we were hearing from doctors at the time that training is too rigid, they have to make decisions too early, and they don't want to sort of enter a sausage machine of training and come out a few years later with a CCT. So this work was undertaken to have a look at how it could be more flexible, and it really did highlight the inflexibility of the current model of training. And one of the main complaints of trainees was this snakes and ladders effect, that if they'd gone into the sort of program and wanted to do one specialty, but halfway through decided that wasn't for them, really the only way to change specialty is to go back to the beginning and start again. And at that time, there was no way to have any competencies that you'd developed already recognised in another training program. So recognising what you'd done in medicine might have some transferability to general practice or other variations. So quite a bit of work has been done in this area, and it's still ongoing at the moment. So from the GMC perspective, the GMC's reviews the standards for education and training and changed those standards so that we now have curriculum standards which are called Excellence by Design and generic professional capability standards. And that's a really important change because it means that we've moved to more outcomes-based training, which does mean that we can get some of that greater flexibility. So we're looking at more global outcomes rather than very detailed items of training. So the framework has changed, and there's now a UK-wide curriculum oversight group to look and ensure there's coherence between different curricula and training across the UK using these two sets of new standards. So where are we now with the flexibility changes? Well, as I've said, we've been, the GMC is exploring the changes that we can make. So the work that the GMC does is obviously dictated by the Medical Act, and we're looking to explore what changes we can make in terms of flexibility within the terms of that Act. So that's the changes I've described so far. And we're working with the Academy of Medical Royal Colleges to look at guidance, and they're producing guidance on how trainees and when trainees might be able to transfer from one specialty to another. And as I say, there's an increasing work ongoing in the curriculum oversight group and with the Royal Colleges to try and develop learning content which can be shared between specialties. There's some particular interest around this, around things like eating disorders, to make sure that the content can be shared between relevant curricula and other areas so that trainees could count that training as well if they decided to change specialties. So we've talked about some of these things, but I thought just to highlight there's some interesting programs as well as the transferring between specialty work. In England, Health Education England are piloting programs where trainees can take a pause from training, so-called step-on, step-off training. These are all quite innovative programs, and there are various opinions about these. And the GMC is supportive in principle and sort of waiting for the results of the evaluation to decide on next steps. We've talked about sharing outcomes between specialties and looking for areas of curricular content that can be shared. And importantly as well, looking at the future, as we said, of CSER, and trying to, if we have an outcomes-based approach, we can probably look to change the way that CSER and CCT works, so that if a doctor has trained in a UK training post, in a placement that's equivalent to a training post, but hasn't done the whole programme, we would hope that eventually, rather than a CSER, that person may be able to go the CCT route. But that does require some legislative change as well, so that's work in progress. And other changes that are happening in postgraduate education is around credentialing. So I wanted to sort of say a few words of update about the GMC regulated credentials. So the term credential can apply to many different types of qualification. So I'm really just going to talk about the work that the GMC's decided to do on regulated credentials from our perspective. So the GMC Council has decided that the credentials we look at will need to meet these three criteria. So there'll be credentials that address significant patient safety risks, that enhance training and meet patient and service needs, and that support this flexibility agenda and innovation in training. So those are the three sort of headline criteria. And the GMC regulated credentials will be aimed at doctors who are on the medical register. They'll have a limited scope of practice, and the eligibility criteria will be quite clear. and the permissions for a credential will be proportionate to the risk in patient safety. And once a credential has moved forward, it'll be subject to assurance procedures, GMC approval and ongoing assurance under the current standards. And I thought you might like to see some of the early adopter areas which are being explored. And really these areas are helping the GMC to sort of test the processes. Obviously the standards we're describing and the processes were designed for medical training, not specifically for credentials. And we recognise there's going to be a lot of learning as we go through this journey, and we'll see whether other changes need to be made. But the 5 areas which are being sort of worked up at the moment are looking at credentials in liaison psychiatry, in pain management, in rural and remote health, particularly in Scotland and some other areas of the UK, cosmetic surgery, and in interventional neurology, or previously known as medical thrombectomy. And the regulation process at the moment is those 5 early adopters are working up their initial proposals, and those initial proposals some of them have recently gone to the curriculum oversight group. And that group gives a 4 UK nation perspective, and that group can look at the purpose of the credential and test that they meet those 3 standards I showed at the beginning about do they meet the criteria for patient safety risk, service and patient needs, and addressing some of the need for flexibility and innovation in training. That's where we've got up to at the moment, but the plan is once those 5 early adopters have progressed through that stage, hopefully that then a full proposal will be worked up for curriculum, which will be go forward to the curriculum advisory group, and the curriculum will be reviewed according to the standards excellence by design, and then go to the GMC Council for approval. And again, the timeline for this, because this is again work in progress. So the launch of the system I mentioned just now was approved in June. We've just recently completed the task and finish groups for the early adopters, and over the next couple of years these will be moving forward through the curriculum approval and hopefully on for approval by the council. Once this process has been tested and we have a robust process, then we'll be able to look at other ideas and proposals for new credentials. So again, just one area I thought might be of interest to mention when we're thinking about postgraduate education is about the regulation of medical associate professionals. And I say people will know that the GMC were asked by the government just not very long ago, a month or 2 ago, to look at the regulation of MAPs, and this will cover, at the moment, will cover physician associate roles and anaesthetic associates. And just so we clarify the roles that we're talking about, physician associates are medically trained generalist healthcare professionals who work alongside doctors and provide medical care as part of the team. They have a defined scope of practice and they work within limited limits of competence, and they're currently unable to prescribe or request ionising regulation. I think it's important to say that regulating them won't automatically change that at the outset. Anaesthetic associates do similar in the anaesthetic world. They work with a consultant anaesthetist and undertake various duties in patients' care at the time of surgery. So where are we up to? This is really at the very beginnings, the MAPS work. So this is a small but increasing number of professionals in this group. There are now 37 course providers for physicians associates. There's only 1 for anaesthetic associates. And I think it's just interesting to note that we're expecting almost 6,000 physicians associates to be trained in a couple of years' time. So whilst they're small in number at the moment, with 37 courses, the numbers are growing quite quickly. And just in terms of how are we beginning to approach the regulation of this group of professionals, the GMC's got some initial sort of start-up funding from the Department of Health to explore the regulatory model. And these are the principles we're starting out with at the moment. So we think it's important that the regulation needs to be proportionate. So as I've described the role, the regulation of PAs or MAPs does not need to be the same as doctors. It needs to be proportionate to the level of clinical risk. We need to make sure that the legislation's fit for purpose, and rather than, as we've talked about, the inflexible regulation we have for medical training, we would like to make sure there's some future-proofing in the legislation, that there might be more flexibility for this group of professionals in the future. It's important that as a regulator, we make sure we have parity of esteem between the professions that we regulate. And it's been clearly said that there won't be cross-subsidisation, so doctors will not be funding the regulation of physicians' associates. One of the good things about physicians' associates, or MAPs in general, is that there's quite a lot of background being done there already. So where possible, we'll look at lifting and shifting some of the good work that's been done already, especially within the faculty at the College of Physicians here, to move that forward. And all of that work will be informed by external engagement with colleagues, with MAPS professionals themselves, and we've really just started on this journey. So where are we up to now? I think we've more or less described some of those things. I'm just conscious of the time, but we're hoping to get to the point of that legislation and that regulation within a couple of years, so there's a lot of work to do. Some of the key issues and questions, as we've said, how far is the legislation we have going to be suitable for MAPs? What needs to be in place at the start of regulation, and what could we do over a longer time scale? I'd be really interested to hear if there's anything that you all think today that we should be considering as well. So one of the other main priorities for the GMC is to ensure training is fair and that we protect the quality of training. And we do this through standards, surveys, quality monitoring, quality reviews, etc. And I think many of you will be familiar with the National Training Survey that runs every year and has a very high response rate from UK trainees, with just about 95% of them completing the survey. So this gives some really valuable data. And it's really important when we're thinking about our doctors in training, just to look at some of the key findings from this survey this year. Although 75% said their teaching was good or very good, which is good to hear, over a third said the intensity of their work was very heavy. Many didn't know who to speak to if they had a concern about their own health and well-being. There were some problems with receiving rotas and lots of comments about poor facilities. So we know that we need to support the profession under pressure. As I mentioned at the beginning, that's something that the GMC has many themes of work on at the moment, which are shown in this slide. And I just wanted to say a couple of words about the work that's been done to support the well-being of doctors. So the GMC published a report a week or two ago, which you may have seen. It's a report done by Professor Michael West called Caring for Doctors, Caring for Patients. And Professor West, in this report, which he co-authored with Dame Denise Coyer, makes some really important points. And I've tried to put some of there's lots of good recommendations in this report, but the key things, I think, is he says that when staff wellbeing is prioritised, there's much less risk of clinical errors, patient satisfaction is higher, and workforce retention improves. And we certainly need to retain our workforce. Creating supportive environments is key to well-being, and we know that there are some great examples in this report of work that's been done to enhance well-being, but it's fairly inconsistent across the UK. Some of the key themes that comes out of Professor West's report is that what's really important is that doctors have autonomy and some control over their work conditions, over their rotas, and that they have voice and influence, and that there's some fairness in the system and perceived to be so. Also, we want to feel part of a community as doctors. We want to belong as part of a team. And we know that clinical leadership and having a positive culture is absolutely key. And that as doctors, we want to be enabled to be competent. So doctors want to do a good job, but to do that, the workload has to be managed. They need to be well led clinically and managerially, and they need to have time for learning, training and development. And I think it's really worth having a look at Professor West's report, because he makes some excellent comments about well-being, and there's some really good examples of where people are doing some outstanding things around the country. So from the GMC perspective, we'll be working with stakeholders to try and support some of the implementation of his recommendations. So just to conclude, because I'm conscious of the time, I hope I've been able to show you some of the priorities for education training, albeit fairly rapidly, to sort of show that we need to shape training to meet the needs of the workforce, but also of our patients. We need to make sure training is more flexible. That's what our trainees are telling us. And that we need, whilst we're making those changes, we need to protect the quality of training, and we need to make sure our training is fair and it doesn't vary where you live or where you train. And fundamental to all of that, and as we've said in retaining our workforce, is at the GMC we are conscious of the fact that we need to be supporting the profession under pressure, and I say Michael West's report hopefully is a good step forward with that. I just want to finish with this slide about William Osler, which again, when I was looking at this prior to the talk, I think in this quote, which is too long to read out, he just about captures all the elements of good medical practice that we have today, which I think is really amazing. Thank you.